about 9, and I would like to invite our moderators, Dr. Gaurav Singh, Dr. Ashish Mishra, Dr. Kilol, Chairpersons Parag Sheth, Harsh Gonia, and Ronak Shah for the next session. I request Chair to introduce the topics. Next slide. Stuti, next slide. Chairpersons or moderators, please go ahead and describe the case and invite the speakers, please.
Hello, I'm audible?
Yes,
Parag, am I audible?
Yes.
Okay, so this is a very interesting topic because we come across to ST elevation MIs and cardiogenic shock not infrequently. And cardiogenic shock following hyperacute MIs leads to almost 50% of mortality, and it's a very important cause for mortality. So the conventional treatment in such patients is to do primary PCI or primary cabbages, and usually most of the units, they put these patients on intra-aortic balloon pump. Now we know the basics of intra-aortic balloon pump, like it augments the diastolic filling of the coronaries and thereby increase the oxygen supply, and it reduces the afterload, and that's how it reduces the oxygen requirement.
Maybe we can take all that discussion after the talks. If you can invite the speakers for the talk, and then we can take a long discussion on this.
Dr. Sanjay Shah is an interventional cardiologist. We all know him for years. He has been doing a great work. He's currently working at Apex Heart Hospital, and he has numerous publications. And I invite him to start this topic of him on intra-aortic balloon pump in hyperacute anterior MI.
Hello. Good afternoon. Can you hear me? Hello.
Yeah, you are audible.
Okay. So I'm starting my topic. The case of hyperacute anterior MI, 38 years old male patient present with pulse rate of 115 per minute with blood pressure of 80/55 with low dose noradrenaline infusion with oxygen saturation 94%, who is having bibasal crepts, who is on ventilator. COVID-19 test is negative, and is shifted for the Cath lab for primary PCI with pH of 7.1 and serum lactate 9.8. Echo shows 30 to 25% ejection fraction and moderate ischemic MR, and preferred mechanical assist device for PCI in this cardiogenic shock would be, obviously this patient is in cardiogenic shock and needs mechanical circulatory support. I will prefer Iabp. Intra-aortic balloon pump is the most widely used mechanical circulatory support device. It allows augmentation of the diastolic blood pressure, improvement of coronary perfusion, and reduction of myocardial oxygen consumption with a small but significant effect on cardiac output. Patient is having moderate MR, which is also an ideal indication for Iabp as it improves hemodynamics in MR significantly. Advantages of Iabp compared to other devices. First of all, it is relatively cheap. Iabp are easily available even in non-tertiary centers. Insertion of Iabp device is more straightforward and can be performed in the intensive care unit without the need of fluoroscopy. It takes about 5 to 10 minutes. Requires only 7.5 to 8 French teeth. Compared with other device, Iabp placement is associated with fewer adverse events like vascular complication or hemolysis. and no extra dose of heparin is required. Conventional dose is okay. Let us talk regarding the various trials of the mechanical circulatory support device in patients with myocardial infarction with cardiogenic shock in whom primary PCI is planned. So this is a Iabp shock true trial published in NEJM 2012, where intra-aortic valve 600 patients were randomized to either Iabp or no Iabp in acute myocardial infarction with cardiogenic shock condition. And this trial shows Iabp does not improve the mortality in myocardial infarction patient with cardiogenic shock. And the 6-year follow-up, the same study also show no survival benefit after 6 years in Iabp group. This is just a complication of various devices. Left atrial assist device versus intra-aortic balloon pump in acute myocardial infarction with cardiogenic shock. So the complication rate was 69% with other device compared to 54%. This is one another article where Iabp and ECMO both are used in the same condition, only in 18 patients, where the outcome was better when Iabp and ECMO both were used in the patient compared to ECMO alone. This is an article published in Open Heart in 2019, where Impella was compared with intra-aortic balloon pump in acute myocardial infarction with cardiogenic shock. Here also, the 30-day mortality was not improved with an Impella device compared to Iabp. So both mortality was equal in both arms. Again, Impress in severe shock trial, which is published in 2017 in JAC. It is a percutaneous mechanical circulatory support versus intra-aortic balloon pump in cardiogenic shock after acute myocardial infarction. Here also the 30-day mortality was the same amongst all devices. This was very early publications when Impella was introduced. Impella was compared with intra-aortic balloon pump, and the result of this trial, the Impella is visible and safe and provides superior hemodynamic support compared to Iabp, but 30-day mortality was 46% in both the groups. Reason of the failure of survival benefit for all devices because of extensive irreversible damage due to large territory involvement and prolonged CPR in significant number of patients. Iabp did not provide any benefit in Iabp shock trial. So several recent studies demonstrate that the use of larger PPCI balloons resulted in greater reduction in cardiac filling pressures and increased cardiac output compared to 40 cc intra-aortic balloon pumps. Unfortunately, 50 cc balloons were introduced in 2012, so it was not used at that time. There was a crossover of 10% of patients in control group to Iabp who developed mechanical complication like the ventricular septal defect or capillary muscle rupture, in whom prognosis is worse. Finally, large percentage of these patients were on vasopressors or inotrope. Thus, Iabp therapy might have been initiated too late in these patients. However, the procedure safety was more and one-day mortality was significantly less in Iabp shock 2 trial. This is evident from this graph. The red one is the Iabp and blue one is the control group. One-day mortality was 9% in Iabp group. However, it was 14% in control group. So one-day mortality was reduced to 35% in this trial, but this was not the primary or secondary endpoint in this study, so it was not given in the conclusion. To me, Iabp mimics the trials of diuretic trials. Diuretics also show no survival benefit in the patients with heart failure. However, in patients with acute LVF, whenever they come to the hospital, all physicians and cardiologists use diuretics to bail out the patients from the crisis, and mostly they are successful. But still it is not showing any survival benefits. So the same role is with the Iabp, where you don't see the survival benefit in the long term, but definitely every cardiologist would like to use IABP whenever patient is in shock. Thanks.
Thank you, sir, for the excellent presentation. Now I invite Dr. Manoj to continue with his presentation on Impella.
Good evening, dear panelists. I'm delighted to be part of this national debate as part of CARDIOCON 2021. In acute MI cardiogenic shock, I'm to debate on Impella as the way forward. This is a 38-year-old man with anterior wall STEMI, resting heart rate 115 per minute, blood pressure on the lower side on IV noradrenaline, hypoxic on ventilator, significant drop in pH with metabolic acidosis, lactic acid is significantly elevated with 9.8, moderate mitral regurgitation, and LV dysfunction with the EF of 25%, which satisfies all the hemodynamic criteria to define the cardiogenic shock in a STEMI patient. So let's see how the Impella is going to interrupt this vicious cycle and try to recover the patients and myocardial recovery as well as salvage the patient and survive him. So a guideline from ESC from PCI and acute MI cardiogenic shock indicates that emergency PCI or emergency CABG for STEMI or NSTEMI ACS with cardiogenic shock is independent of time delay of the symptom onset. So there is no time window for treating revascularization in such patients with cardiogenic shock, and it's a class 1 level of evidence B indication, as also the mechanical complications associated indicates PCI without any particular time frame. So if you look at the various mechanical circulatory assist support, you would see that multiple devices are available. But the tandem heart is to be implanted surgically and out of consideration in many of the centers worldwide. If you look at the cardiac output from the various devices, the Iabp offers only about 0.5 liters increment over the baseline cardiac output in a patient with cardiogenic shock, whereas the diastolic augmentation is not necessarily an augmented cardiac output from the Iabp. So you would see that from Impella and ECMO, 3.5 to more than 5 liters can be obtained by use of these mechanical circulatory assist devices. You would know that Iabp shock 1 and 2, the randomized controlled trial, did not show any hemodynamic benefit nor survival benefit by the use of Iabp. And both the European and American guideline recommendations for Iabp were downgraded recently for class 3B in the ESC recommendation and 2B with level of evidence B in ACC-AHA. So the new cardiogenic shock indicated therapy is the Impella. And you would see that the mortality of acute MI cardiogenic shock and mortality in acute MI cardiogenic shock with the surgically implanted versus no ventricular assist devices is significantly dropped by the use of peripheral or a percutaneous ventricular assist device, which is the Impella. So you would see that 52 to 43% and 56 to 42%, depending on the type of device that used. So what is meant by load on the ventricle? Anything which increases the myocardial oxygen demand, the various parameters are indicated, the heart rate, wall stress, systolic pressure, diastolic pressure, LV stroke work, is the load on the ventricle. So you would see that whenever the LVDP increases more than 18 millimeters of mercury, it's associated with an increased risk of heart failure in STEMI, as also once the LVDP crosses 18 millimeters, there's a decrease in the coronary blood flow and myocardial perfusion. Any LVDP of more than 24 millimeters mercury is a predictor of high mortality in STEMI patients. So what happens when you introduce Impella? It draws the blood from the ventricle and drives across the mitral valve into its outflow in the aortic road, and therefore it decongests the ventricle and unloads the ventricle. Thereby there's an increase in the flow, increase in the mean arterial pressure, and total cardiac power output or cardiac index improves. And thereby by pumping out of the blood from the ventricle, it reduces the LV and diastolic volume and diastolic pressure. There's reduced wall tension, reduced mechanical work for the ventricle, the decrease in the microvascular resistance that translates into increased coronary blood flow. So by all this means that Impella increases the oxygen supply to the coronary and myocardium, as well as reduces the myocardial oxygen demand, unloading of the ventricle leads to significant myocardial recovery. You will see that in a failing native heart, when you introduce Impella, the native cardiac index comes down, which is a ventricular unloading, and an augmented Impella adds to its cardiac output, and there's an augmented cardiac index. So even if the native cardiac output brings down, the Impella assists that and augments the cardiac output and sustains a higher output and leaves the ventricle for resting. So this is not happening with the Iabp. You will see there is no augmentation of the cardiac index or cardiac output with the use of Iabp. You would appreciate that in this patient, the ventricle is significantly poor in a systolic contractility. You will see that the Impella and unloading a significant amount of contractile reserve, which is improved by unloading and improved coronary flow. And therefore, with the mean arterial pressure increases, the cardiac output increases, cardiac power output increases, pulmonary capsular wedge pressure reduces with the continued use of Impella. So the coronary blood flow is also related to a product of aortic pressure and the microvascular resistance. It is understood that increasing performance of the Impella with larger output from the Impella, there is a progressive decline in the microvascular resistance that increases the coronary blood flow proportionate to the performance of the Impella. Animal studies have shown that from the baseline, compared to the use of Impella, compared to the use of Iabp, which increases the coronary blood flow from baseline by 13%, the use of Impella increases the coronary blood flow by a whooping 47%. You will show that it translates into the myocardial recovery here with the use of Impella than when it's underperfused, when there is no mechanical circulatory support. The hemodynamic further simulation shows that in the absence of any support, there is no augmentation of the coronary blood flow. With the Iabp, there's an early diastolic augmentation, but as the balloon deflates in the late diastole, the coronary blood flow becomes less. This is well sustained throughout the diastolic period with the use the cardiac output increases, the coronary blood flow from baseline by 13%. The use of Impella increases the coronary blood flow by a whooping 47%. You will show that it translates into the myocardial recovery here with the use of Impella than when it's underperfused, when there is no mechanical circulatory support. The hemodynamic further simulation shows that in the absence of any support, there is no augmentation of the coronary blood flow. With the Iabp, there's an early diastolic augmentation, but as the balloon deflates in the late diastole, the coronary blood flow becomes less. This is well sustained throughout the diastolic period with the use of Impella. So the Impella continuously augments throughout the whole of the diastole, the coronary blood flow. This translates into an effective increase in the pressure as well as the volume loop, which moves to the right and is much, much favorable, which we don't see with the Iabp or the ECMO, which increases the load on the ventricle. So therefore, the Impella is an effective, the first and perfect technology, and is a viable percutaneous cardiac assist device, which can be placed percutaneously. It increases the net cardiac output, which translates into better systemic higher hemodynamic perfusion. It reduces the oxygen demand and increases the oxygen supply, and therefore provides the mechanical myocardial protection. So the Impella flow path mimics the natural direction of forward flow from the ventricle across the aortic valve into the aorta, and conveys the blood to the systemic as well as the coronary circulation. And therefore, there is an innate ability of the Impella to simultaneously provide systemic hemodynamic support and myocardial protection, which is a fundamental principle of the support from Impella. This translates into effective tissue perfusion, which is a significant progressive decline in the blood lactate levels in the treatment of cardiogenic shock. A recent issue of meta-analysis published in the JACC showed that among the 3 studies considered, you would see that there was an early Impella used during cardiogenic shock and an acute MI. It translates into almost 48% increase in the survival as compared to not using Impella at the right time. It is also understood that use of Impella significantly reduces by 1/3 the major adverse cardiac and cerebrovascular events, And this is also translated into post-discharge up to 90 days with the continued benefit in the endpoints of death, stroke, myocardial infarction, repeat revascularization from the discharge to the 90 days. So therefore, Impella in acute MI cardiogenic shock significantly reverses the vicious spiral and allows myocardial recovery and also the patient recovery. The absence of randomized controlled data evidence-based supports a patient care centric, patient-centric team approach. So you would know that it has significantly demonstrated survival in the recent observational registry in the United States and also in the Europe. So the Impella experience gives compelling indication for its use in acute myocardial infarction complicated by cardiogenic shock, and Impella is the way forward, with the caveat that it is the cost of it is prohibitive. Thank you.
Thank you. I would like to request Dr. Dhaval to continue with his talk on ECMO.
Good evening, everyone. Am I audible?
Yes, you are audible, sir.
Hello.
Yes, you are audible, sir. Please go ahead.
Yeah. Thank you very much, Kamal and the entire team actually for keeping these wonderful debates quite interesting. I thank you very much, Sanjay Bhai also and Dr. Manoj for wonderful inputs of Iabp and Impella. So Kamal, I just would like to tell you that this topic about use of mechanical circulatory devices actually it is more actually about learning than debating. So in my topic in this coming 7 minutes, devices rather than debating actually which is good and which is bad. I hope it's okay for everyone. So VA ECMO, as everyone knows, nowadays quite popular. There are so many centers in India, just familiar with ECMO. There is one outflow cannula which sits into the right atrium through femoral vein, and there is an inflow cannula, it sits in the femoral artery to aorta, and we can have either oxygenator in between the circuit if you really need to support the lung. So that is the basic circuit of VA ECMO. Now, this is a very interesting figure. If you look at the figure A, so that shows Iabp, and we can see it can only support the circulation while inflating during the diastole and deflating during systole. So it can increase the cardiac output by maybe 0.5 to 1 liter. Thus, figure B is ECMO, and we can see, it can support from RV to LV, anything. via ECMO. C is a tandem heart. We are not going to discuss. D is Impella, as Dr. Manoj already described about that, which can support only left ventricle. And certainly we also have an Impella RP, so that can support right ventricle alone. What I want to say, actually, when we use the ECMO, via ECMO particularly, it is all up to us which all our system need to be supported, because sometimes in emergency it is a bit difficult to assess right ventricle is in the pulmonary edema or not, and in that situation, most common available is the VA ECMO. Very interesting chart. I just would like to show you only the upper part. Whichever kind of a heart failure, actually, is cardiogenic shock, it is isolated or predominant right ventricular dysfunction. If it is a biventricular, it is predominant left ventricular, or refractory cardiac arrest with the shock. In any form of cardiogenic shock, ECMO can be used, with a bit of precautions and safety, which in most of the other devices have a very specific indications. This is just one small slide to make you understand the complications of each device. Just we don't use tandem heart. So Iabp, as we all know, bit of a chance of infection, bleeding, vessel perforation, retroperitoneal hematoma. If we put, we can still avoid most of these complications. Impella, again, the most common problem is hemorrhage, sometimes CNS infarction, brain death. and seizures, while ECMO is having another set of complications, that is a lot of hemolysis, thrombocytopenia, again, hemorrhage, particularly GI bleed or CNS bleed, and certainly infection. Now, this is the most important slide actually. Now I'm coming to my topic. So look at the carefully. So we have, the patient having a cardiogenic shock, complicating with infraction. So only 50 to 60 patients survive without MCS. What I want to say, 50 to 60% of patients, they don't need actually MCS, or we can just manage with Iabp. So these all are early cardiogenic shock, and that sits in the cohort A. If you look at the right side, there is a cohort C. So 40 to 50 percentage patient, they have a less hope for survival. In that, 25 to 35% of patients, they do not survive with or without MCS. These all are bad patients, or we can say, sick patients. So remaining only 15 to 25% of patients, which sits in cohort B, are possible candidate for mechanical circulatory support. Now, this is very important to understand actually. So all patients are not candidate for MCS. So the selection of the candidate is very much important whenever you select either Impella or ECMO. So if you look at this slide, just go below the second last para. Whenever we have a low cardiac index, that is less than 1.8 liter per minute per meter square with raised pulmonary capillary wedge pressure, and when the PAPI, so that is less than 1, that is definitely an indication for mechanical circulatory support, either of the Impella or ECMO. Certainly, as we already discussed, and Dr. Sanjay Bhai, he already committed in refractory shock, the role of Iabp is now very much limiting. This is one of the paper from the Korea, where the use of Iabp is just drastically coming down, while the use of MCS has just gone up in this set of patients. This slide already we have seen actually, there is a comparison of all devices which are available across the world, but more importantly, whenever we look for the cardiac output actually, the cardiac output is only 0.5 to 1 liter actually with Iabp. So early cardiogenic shock patients only would be benefited with Iabp. Otherwise, if you want more cardiac output, then either we have to go for the 2.5 or 5 liter Impella or ECMO, that is via ECMO. So this is aggregate slide of a device selection actually. As we already said, early cardiogenic shock, Iabp in most of the cases is sufficient, and we all centers actually are used to this practice. But whenever we have an advanced or refractory shock, okay, if patient is unstable, then we have to use VA ECMO, and we have to just wait for the myocardial recovery or heart transplant below by LVAD, whichever the clinical circumstances. But if patient is stable, then we have LVADs, BiVAD or RVAD. We can, if it is only left ventricular failure, then we can use Impella. But if it is a biventricular failure, certainly via ECMO, there is no role of Impella in the presence of RV dysfunction. We can use via ECMO, and then we can manage according to once the patient survives. So these are there are so many papers actually been published regarding the use of mechanical circulatory support in acute cardiogenic shock, and these papers actually, they have quite promising. This is ECMO CS trial actually. The end results has not yet been published, but the early results actually they are quite promising actually. ECMO in MX, like again, mortality is definitely high actually whenever you use MCS in cardiogenic shock, but ECMO can still play an important early role. So that is very important word, early role. Not going in detail, but these all are papers actually. Most of the centers, they have conducted a trial with ECMO. As such, there is no trial there actually, regarding Impella and ECMO comparison. So this is final chart actually whenever we have a patient of cardiogenic shock, that is if early shock, as I said, Iabp, but if aggravating shock, ECMO is always a choice which is readily available in most of the centers nowadays. particularly whenever the patient is having hypoxemia, whenever you are expecting actually CTAP, then the VICMO is the only choice. But you can go through carefully. The indication for Impella is very reserved only for left ventricular failure, and it is absolutely a beautiful machine, I must commit. Now, the problem with Impella actually in India, now we just go through a few points actually, which is really matter of a practice with us. Impella is still not available in most of the centers across India. Dr. Manoj, you must agree with me. I think Delhi and Chennai, but in Gujarat, definitely it is not available. Impella, the ECMO actually, there are so many centers has come up now with the ECMO. In Gujarat, we have so many hospitals actually now they are equipped with ECMO, and so many hospitals, they already started using.
Time is up.
Sir, if you can just summarize.
Yeah, that's what is a summary. So there is no bedside insertion technology available for the Impella. We have to take the patient in cath lab under fluoroscopy. We need definite learning curve for Impella.
I think we have lost the connection with Dr. Dhaval.
It is contraindicated in presence of LV clot, and yeah, so I'm sorry, just took a little bit of a more.
Fantastic talk, all three speakers did fantastic stuff. I think Dr. Dhaval did not make it, a point to prove that ECMO is something that you have to push in an acute coronary syndrome, and Dr. Manoj already had the leverage. And we know a lot of meta-analysis is now being published, a very beautiful meta-analysis, how you look at it. I mean, which kind of cardiogenic shock you are looking at. If you're looking like a primary PCI acute coronary, Impella beats, the in-hospital outcomes, the in-hospital time to discharge, even cost, they mention in European countries being lower with Impella. But as Dr. Dhaval mentioned, when you have no ROC, nothing like ECMO, you can't compete, no spontaneous return of circulation, nothing like ECMO. And as Sanjay pointed out, I mean, you don't end up putting ECMO and Impella in every acute MIs that walk into your lab, because still you have some evidence to talk about with Iabp, especially in acute coronary syndrome. I would like the chairpersons to take over from here. Dr. Harsh, Dr. Ronak, Dr. Parag, Dr. Gaurav Singh, Dr. Ashish Mishra, and Dr. Kilol, your comments, and then we can have a couple of points from each speaker on the same.
No, there is
Dr. Sanjay
no argument here. There is no argument here that mechanical circulatory assist devices, they give a better cardiac output as compared to intra-aortic balloon pump. Intra-aortic balloon pump when gives probably 0.5 liters per minute of increment in the cardiac output, the others do significantly well. So that is known, but issue here is whether it is converted into clinical benefit, whether it is converted into survival benefit at 30 days. There is no difference, and there are no randomized control trials, no RCTs to prove this. Most of them are observational or meta-analyses. And I would ask the supporter for Impella, what will you do if you have, because a lot of hyperacute anterior MIs will have left ventricular clots and all, thrombus. What will you do in such situation? If you have LV clot, what will you do? And say a patient with say significant aortic stenosis, will you do a balloon and then put a Impella, or what will be your choice in such situation? He's a very sick cardiogenic shock patient, PCWP more than 18, blood pressure is just 70-80. What will you do?
I think if in a critical aortic stenosis with need for LV support, there are two aspects. One, those patients are at high risk of ventricular arrhythmias and cardiac arrest. So whenever there's a cardiac arrest, the Impella may not really be useful because it's a load-dependent state. So when the LV is not receiving any flow through the pulmonary veins through the LA into the LV, the Impella may not be of use. So if you think there's a significant support required for the maintaining the circulation, the ECMO supported TAVR is always a better opportunity. But having said that, A few cases have been reported in the literature in these days. In the last few months, we have read of cases where they put Impella balloonoplasty in Impella and then perform the, once they leave the Impella for about 2, 3 to 4 hours, they unload the ventricle, improve the LV dynamics, and then remove the Impella and then put in the TAVR valve. So, but these are all very not guideline directed, these are anecdotal reports. So those concepts are just emerging and evolving. So I don't think anybody has such experience of large volume to give any directions of use of Impella in aortic stenosis patients.
See, I had I had an experience of Impella. What I found the problem actually is time management, because the patient is really, is going in shock, then you have to arrange echocardiography. Actually, most of the time, you need transesophageal echo. And to set that Impella actually across the aortic wall is very crucial. It is very crucial, really. And just, you cannot leave here and there a bit of that portion across the aortic. Like, it is a bit difficult, actually. We have to cut down the femoral artery in most of the cases, because it's a big sheath actually, and we cannot put it percutaneously, because it can damage the device. So in most of the cases, we have to call for the cardiac surgeon team for the backup. They have to just come inside, and then so
that's for Impella 5, Dhaval.
Yeah, it's not really required for a surgical cut down. These days, percutaneous Impella placement is the role, and through a micropuncture, just the same way that you do a TAVR. This is a much lesser, for 13 or 14 French sheath is much lesser in size than the TAVR. So even TAVRs are done percutaneously these days without a cut down. So it depends on the institutional exposure, and many centers who do TAVR percutaneously can also do Impella positioning percutaneously without a surgical cut down.
Now you have Impella MCS is available, which gives 4 liters of cardiac output as compared to Impella 2.5, and it still can be inserted percutaneously. So that thing probably can be taken care of. But more important, most of this MCS, whether Impella or now even HeartMate is coming, because HeartMate is a time-tested device for us all surgeons around the world. HeartMate 2. Now HeartMate PCP, which is same like Impella, it is going to be a microaxial device, and it will be it will give almost 5 liters of cardiac output. So whether percutaneous or surgical cut down of femoral and all probably will be secondary in this severely complicated patients who are fighting for their lives. I mean, if they leave, then only you will have the opportunity to look at their limb complications and all. Also, the limb ischemias and these cut down related issues can be taken care of by suturing an 8mm graft to femoral and then insert this. So, I mean, that probably will not be as important as the final outcome. The most important will be if they survive the 30-day. If 30-day advantage, survival advantage is there, then that will be the best thing, for these patients who have significantly high mortality, cardiogenic shock, 50% mortality in hyperacute MIs.
Dr. Harsh, your comments, Dr. Gaurav, Dr. Ashish, Dr. Kilol.
My question to Dr. Dhaval, is there any particular indication to use ECMO over Impella except the case with LV clot or the aortic stenosis?
Yeah, if patient is having hypoxemia, basically. So if it is biventricular dysfunction, if patient is going into pulmonary edema, just then that is the indication actually, to use VA ECMO over Impella. Let me tell you, Impella can, see, as Dr. Manoj said, you need preload actually for the Impella to work. It is very important to understand, the blood has to reach to the left ventricle. Okay, until unless that Impella cannot work. So if there is a biventricular failure, then the forward flow from the right side is very difficult to achieve. In that case, your Impella is not useful. Then we have to use the VA ECMO. The only See, I'm using ECMO since so many years now. The only problem actually, and the only thing I don't like about ECMO is increase LV afterload. That is the nasty thing actually. When it gives you trouble, it gives you trouble like anything. So that is the only problem with the ECMO, via ECMO. That is
Dr. Canaria, I'll just add that by the guidelines, if a patient had a cardiac arrest and cardiogenic shock has a recurrent ventricular arrhythmias, then ECMO is the most suited, because in a cardiac arrest, Impella may not work, Iabp may not work, so you have a ECMO supporting the systemic circulations. But if you also have a significant RV dysfunction, if you unload the ventricle, it is going to reach the venous circulation and come to the RV, so RV dilates. So if there is an RV dysfunction and a LV clot, you can't use Impella.
Impella, yeah.
Dr. Dhaval, what will you do to reduce the preload because of ECMO? Is there any measures to reduce it during ECMO?
Preload to left ventricle?
Yes, you just mentioned the problem with the ECMO is just
afterload.
Afterload.
Yeah, exactly. So the most common thing actually what we practice is Iabp. If we need, actually we put Iabp. Iabp can take a little bit of afterload, and we keep assessing actually through the echo. Okay. But really, if it is LV is a problem, one of my case of a VA ECMO, just one day the LV was good and second day the LV was full of clots. So that's why I said I don't like actually increase afterload. But then LV venting through the LV apex is one of the easiest and simplest method. And if we have a very good cardiology colleagues, they can do the atrial septostomy. So that will allow to reduce.
I think one has to know that the cost of Impella is significantly high.
Yes.
It is 20 lakhs or more.
No, 7 lakh rupees, I believe. Dr. Manoj, it is available in Chennai?
Yeah, few centers, even my centers do that, but I think it's not 7 lakhs. 7 lakhs is the IVAC, which is available, 7 to 9 lakhs IVAC, intraventricular pump is that. But Impella is 20 lakhs and more.
That's a problem actually in India. I hope, and no one minds actually talk a lot about the technology and everything, but it is very difficult to adapt all this technology because of the cost.
In India, it is difficult to convince the patient for a primary also.
We should get the Atmanirbhar Bharat and devise our own indigenous Impella.
But
Impella we can make.
Using now ECMO, very frequently, as we already started.
Yeah. So thank you all the speakers, moderators, and chairpersons. We had a really nice session, but as we are running short of time, we'll have to end the bout and move to another bout. So please stay with us for the another bout. Thank you.